Hello everyone. As a part of the continuation of the ECG lecture series, in this session I will be discussing about the QT interval. So if you take the QT interval, first of all let me tell you what it exactly represents, and in the ECG complex where it will start and where it will end. So if you take the QT interval, it represents the time taken for ventricular depolarization and as well as repolarization. So in the QT interval, what all the waves you have and what all the segments you have. So you have the QRS complex. So first of all, where it starts and where it ends. The QT interval is the time from the start of the Q wave. So this is the start of the Q wave up to the end of the T wave. So this is what is your QT interval. And what all complexes and segments does it have? Number one, it has the QRS complex. Then we have ST segment. Then we have the T wave. Right? Then we have the T wave. So these are the segments and as well as the waves like what you have in the QT interval. An interval will have a wave and as well as a segment, isoelectric segment. Whereas if you take ST segment, segment means you will have only an isoelectric baseline. You don't have a wave in a segment, right? So this is little basics. Now this particular QT interval, it represents the ventricular depolarization, that is QRS complex, that is ventricular contraction. And it also represents the ventricular repolarization or the ventricular relaxation. So it represents the time taken for both the ventricular contraction, that is QRS complex, and ventricular relaxation, that is the T wave. Now if you take this particular QT interval, it is usually measured in the leads 2. Lead 2, as I have said you in the ECG basics also, that lead 2 is considered as the rhythm strip. That is considered as the standard lead. Why? Because the wave of depolarization or the electrical axis of the entire heart is towards lead 2. So that is the reason why the lead 2 is considered as the standard lead. So in the standard lead, that is lead 2, the QT interval has to be measured. Now followed by that, how to measure the QT interval. So whenever you want to measure the QT interval, several successive beats should be measured with maximum interval taken. Right? Several successive beats should be measured. Now, for suppose, along with the QT interval, after the T wave, if you have a U wave, in such clinical scenario, what is that you should do? For suppose, if there is presence of a large U wave, right? So U wave is the wave which appears after the T wave. So if you have a large U wave that is fused to the T wave, even then that particular large U wave should be included in the measurement. Okay, see this is the U wave. So this particular U wave which is fused to the T wave, which is having a large amplitude, that should be included in the measurement. Whereas if the ECG complex has the smaller U wave, right? So this is the smaller U wave. In such clinical scenario, the U wave should be excluded, right? So smaller U wave and those that are separate from the T wave should be excluded. So this U wave should be excluded. So now in such case, the QT interval should be up to the end of the T wave. Right? Up to the end of the T wave. So this is about the basic introduction of the QT interval. How you have to measure the QT interval, from where to where is your QT interval, and what actually the QT interval represents. Now, how to measure the QT interval when there is tachycardia or bradycardia in the patient. Like you just see a multiple choice question here. For calculation of rate related QT interval, the QT interval is divided by root of x. What is this particular x? First option is the PR interval. Second option is from the starting of the P wave to the end of the S wave. And third option, it is your ST segment. And fourth option, it is from R wave of one particular complex to that of the other complex, right? So this we call it as RR interval. Right? This we call it as RR interval. So for calculation of rate related QT interval, the QT is divided by root of x, where x is. Here the x is the option 4. That is QT interval, that is QT of RR interval. That is what is nothing but a corrected QT interval. And what is this formula called as? This particular formula is called as the Bézet formula. So what is Bézet's formula? The corrected QT interval is equal to QT divided by root of RR interval. So what is the purpose of this particular corrected QT interval? The corrected QT interval, that is QTC, C means corrected. This will estimate the QT interval, right? This will estimate the QT interval at a standard heart rate of 60 beats per minute. Now what is its use? This allows the comparison of the QT values over time at different heart rates and improves the detection of the patients at risk of the arrhythmias. So the purpose of this particular corrected QT interval is to see that if the individual is having either bradycardia or tachycardia, in such clinical scenario, you need to measure what is called QTC, that is corrected QT interval. So this allows comparison of the QT values over time at different heart rates and improves the detection of the patients at increased risk of the arrhythmias. Okay. Now, for measuring the corrected QT interval, we have the various formulas. That includes the following. Which of the formula is not used to estimate the corrected QT interval? Bézet formula, Fredericia formula, Framingham formula, Gorlin's formula. So the one which is not used, Bézet's formula, definitely we use that. Just now I have explained you about that Bézet's formula. Fredericia formula is being used for estimating the corrected QT interval, and even Framingham formula is also used, but not the Gorlin's formula. So we don't use the Gorlin's formula for estimating the corrected QT interval. Now what are all the various formulas? Let me show you. So these are like multiple formulas used to estimate the corrected QT interval. So it is not clear which formula is the most useful, but these are all the various formulas. Bézet formula, QTC is equal to QT by root of RR interval. Then Fredericia formula, that is QT interval by RR to the power of 1/3. Framingham's formula, that is QT plus 0.154 multiplied by 1 minus RR interval. Then we have the Hodges formula. So these are all the formulas what we use for measuring the corrected QT interval, right? And what is the use of this particular corrected QT interval? This point is very important. Like why we are using this particular corrected QT interval? This is mainly to estimate the QT interval at a standard heart rate of 60 beats per minute. For example, if the individual is having the heart rate of more than 100, then you apply the corrected QT interval for estimating what exactly is the QT interval. For example, if the individual is having bradycardia, that is heart rate less than 60, In such case also you apply this particular, the corrected QT interval. That will give you the QT interval at a standard heart rate of 60 beats per minute. And thereby it improves the detection of the patients at increased risk of the arrhythmias. Now, after having discussed about the various formulas for the QT interval, you need to know how much is the normal QT interval. So you see this. So the question is, normal QT interval is 120 to 200 milliseconds, 360 to 440 milliseconds, 70 to 100 milliseconds, 200 to 400 milliseconds. So the normal QT interval, it is around 360 to 440 milliseconds. That is a normal QT interval. But this particular value, it changes in men and as well as the women. So you take the QTC, it is prolonged if it is more than 440 milliseconds in men, or the QTEC is considered as prolonged if the QT interval is more than 460 milliseconds in women. So this is about the normal QT interval. And when the QT interval, if it is more than 500 milliseconds, they are the patients who are at increased risk of the Torsades de Pointes. So now what is this Torsades de Pointes? That is polymorphic ventricular tachycardia. Right? Polymorphic ventricular tachycardia is nothing but your Torsades de Pointes. And when do we consider that the QT interval is abnormally short? When the QT interval is less than 350 milliseconds. That is the point when we consider it as the QTC is being short. So normal QT interval is around 360 to 4 seconds. Now let me discuss the clinical scenarios where you have the prolonged QT interval and the clinical scenarios where you have short QT interval. Now you see a question, which electrolyte abnormality does not cause the QT prolongation? The options are hypokalemia, hypomagnesemia, hypocalcemia and hyponatremia. So the question is, does not cause QT prolongation. All these particular hypos, hypokalemia, hypocalcemia, hypomagnesemia, all these can cause the QT prolongation. But the disorder associated with the sodium, that is hyponatremia, does not cause the prolongation of the QT interval. Does not cause. Now, let me discuss some more causes. Okay, before that, you take the hypokalemia. Let me discuss option by option. First of all, you take hypokalemia. In hypokalemia, it is not just only QT prolongation. There are many ECG changes in patients with the hypokalemia. Now, what are those ECG changes in patients with the hypokalemia? That includes the following. So, the first and foremost, the very important change is the appearance of the U wave. Right? The appearance of the U wave, and that too, that U wave will be a prominent U wave. Then, followed by that, you take the T wave. The T wave, either it will be flattened or it will be inverted. So, the T wave flattening and T wave inversion is being observed. Right? T wave flattening and T wave inversion is being observed. Then followed by that, you take the QT interval. So what will happen to this particular QT interval? The QT interval, it is apparently long QT interval. Right? Apparently long QT interval. Right? And this particular long QT interval, apparent, why am I using the word apparent? If I also consider the U wave into the T wave, then apparent long QT interval due to fusion of the T and as well as the U wave. Okay, next. So, first appearance of the U wave. Second, the T wave flattening or inversion. Then the QT interval prolongation. Then if you take the ST segment, the ST segment will be depressed. Right? There will be depression of the ST segment. Then followed by that, you take the PR interval. The PR interval is also prolonged in patients with hypokalemia, and there will be increase in the amplitude of the P wave, that we call it as pseudo-P-pulmonale. Right, that we call it as pseudo-P-pulmonale. So that is what you will see in case of the hypokalemia. So in hypokalemia, apart from QT interval prolongation, PR interval will be prolonged, ST segment will be depressed, the T wave will be flat or inverted, and appearance of the U wave will be there, and the amplitude of the P wave will be peaked. That is called pseudo-P-pulmonale. And let me just show you an ECG with all these changes. So this is the ECG of hypokalemia. Right, this is the ECG of hypokalemia. So what is that you are observing here? You see, you have the presence of the U wave. Then the T wave, it is being inverted. Right, the T wave is being inverted. And if you calculate the QT interval, right, that is prolonged. And it is apparent QT interval because you need to also consider the U wave being fused with the T wave. And you take the ST segment, the ST segment is depressed. Right, ST segment is depressed. And the other changes like what you will have in hypokalemia, the PR interval will be prolonged and you will have the prominent P wave. So you don't have that changes in this particular ECG, but as the severity of the hypokalemia increases, you can also see those particular changes as well. So the basic purpose of showing you this particular ECG is to show that the QT interval will be prolonged in patients with hypokalemia, but in hypokalemia, along with the QT interval prolongation, there are many other changes that you will notice. Alright, next. Now, what are the other causes? So, one cause we have just now discussed, that is hypokalemia. And the other cause include the hypocalcemia. And the other causes of the QT interval is the hypocalcemia. Now let me just show you an ECG of the hypocalcemia where the QT interval is being prolonged. So this is the ECG change in hypocalcemia. So in hypocalcemia, you take here, this is your QT interval, right? And in this patient, the QT interval is nearly around 480 milliseconds or 0.48 seconds. And in hypocalcemia, you will have prolonged QT interval, whereas in hypercalcemia, you will have a short QT interval. Right, you will have a short QT interval, whereas this one is your normal QT interval, that is 360 to 440 milliseconds. That is what is the normal QT interval. So hypocalcemia, prolonged QT interval. Hypercalcemia, short QT interval, right? So that is what is the changes of QT interval you will have in patients with the hypocalcemia. Now, followed by that, apart from hypocalcemia, the other electrolyte abnormality where you will have the prolonged QT interval is in patients with the hypomagnesemia. You take the normal magnesium levels. Normal magnesium levels are 0.8 to 1 millimoles per liter. Right, 0.8 to 1 millimole per liter. That is nothing but equivalent to 1.5 to 2 milliequivalent per liter. And when do we use the word hypomagnesemia? When it is less than 0.8 millimoles per liter. Right, when it is less than 0.8 millimoles per liter, then we use the word hypomagnesemia. And in hypomagnesemia, the primary ECG abnormality seen with hypomagnesemia is prolonged QT interval. Right, prolonged QT interval. Now these patients with the hypomagnesemia causing prolonged QT interval, they can progress to the development of the polymorphic ventricular tachycardia. So this is the ECG with polymorphic ventricular tachycardia. And this polymorphic ventricular tachycardia is the precipitation of this prolonged QT interval. Okay, so you see here in early part of your ECG complexes, you have the presence of the prolonged QT interval, right? So this prolonged QT interval will progress to tachycardia, and this particular tachycardia is polymorphic because these QRS complexes, they are of not similar morphology. So that is why it is called polymorphic ventricular tachycardia. So polymorphic ventricular tachycardia is what develops in patients with hypomagnesemia, and that is called as Torsades de Pointes. Called as the Torsades de Pointes. And this particular Torsades de Pointes is the one which can make the individual to land up in the sudden cardiac death. So hypomagnesemia is a life-threatening condition where the individual can have a sudden cardiac death. Now, apart from the electrolyte abnormalities, what are the other conditions where you will have the prolonged QT interval? Next question, if you see, the QT interval prolongation is seen in all except hypothermia, digitalis toxicity, hypocalcemia, Romanov-Ward syndrome. Now, hypocalcemia, just now we have discussed, definitely there will be QT prolongation. But in case of digitalis toxicity, you will have the shortening of the QT interval because digitalis is the drug which will increase the myocardial contractility. So by increasing the myocardial contractility, the QT interval will be shortened in case of the digitalis toxicity. Whereas in hypothermia, hypocalcemia and Romanov-Ward syndrome, there will be QT prolongation. Now, what is this particular Romanov-Ward syndrome? Romanov-Ward syndrome, it is a congenital cause for long QT syndrome. Now, the point here is, what are the congenital causes for the long QT syndrome, right? You see this question. The congenital long QT syndrome is seen in case of Romanov-Ward syndrome, and the other condition where you will have the long QT syndrome is in case of Jervell and Lange-Nielsen syndrome. Right, Jervell and as well as the Lange-Nielsen syndrome. So these are the two conditions, congenital causes for long QT syndrome. And there is one important multiple choice question related to your Jervell and Lange-Nielsen syndrome. What is that? So in this Jervell and Lange-Nielsen syndrome, there is the hearing loss. What type of hearing loss is seen in Jervell and Lange-Nielsen syndrome? Sensory neural hearing loss, the conducting hearing loss, both. The answer to this question is the sensory neural hearing loss. So, if you take the congenital causes for long QT syndrome, in Romanov-Ward syndrome, you will have the normal hearing. But whereas in case of Jervell and Lange-Nielsen syndrome, you have the sensory neural hearing loss. Right? You have the sensory neural hearing loss. So, in both of these particular clinical scenarios, the treatment of choice will be beta blockers. Okay? Right. In between these two, if you take the Romanov-Ward syndrome, the Romanov-Ward syndrome is the most common form of the congenital long QT syndrome. So in this particular clinical condition of the Romanov-Ward, it will affect the electrical properties of the heart muscle cells. And in these individuals, along with the long QT syndrome causing abnormal heart rhythms, these individuals will also have the fainting spells, seizures, or the sudden cardiac death. Now, apart from this particular, the congenital long QT syndrome, what are the other conditions where you can have the long QT syndrome? You see a multiple choice question. So the question is, cerebral T waves are seen in multiple sclerosis, subarachnoid hemorrhage, hypoxic ischemic encephalopathy, hyperthermia. So cerebral T waves, what do you mean by this? They are nothing but there will be global T wave inversion, right? So you have the presence of global T wave inversion, and this particular cerebral T waves are seen in a clinical scenario where there is raised intracranial pressure, right? Where there is raised intracranial pressure. Now, among the options given to you, where do you have this particular raised intracranial pressure? That is seen in patients with a subarachnoid hemorrhage. So in subarachnoid hemorrhage, you will have widespread T wave inversion due to subarachnoid hemorrhage, right? Now I'll just show you that particular ECG as well. So this is the ECG of the raised intracranial pressure. So in case of raised intracranial pressure, you will have widespread T wave inversions, right? So these are your widespread T wave inversions. Now, why am I discussing this in the context of the QT interval? Remember, raised intracranial pressure is also one of the cause for the prolonged QT interval. So, in raised intracranial pressure, there will be cerebral T waves, that is global T wave inversion, and along with that, there will be prolonged QT interval. So, to summarize the causes of prolonged QT interval until now, electrolyte abnormalities like hypokalemia, hypomagnesemia and hypocalcemia, and then raised intracranial pressure and the congenital long QT syndrome or congenital long QT, the conditions of Jervell and Lange-Nielsen syndrome and as well as Romanov-Vand syndrome. Now, apart from these conditions, the other clinical scenarios where you can have this particular prolonged QT interval is, I'll just show you one ECG complex. Right. So, if you take this particular ECG complex here, definitely you have the prolonged QT interval. Along with the prolonged QT interval, there is some abnormal wave which you need to identify. So, at J point, you have a blip. Right? At J point, you have the blip in almost all the leads like V3, V4 and as well as V5. Now, what is this particular small blip at this particular J point is nothing but your Osborn wave. Now, where do you come across this particular Osborn wave? You will come across this particular Osborn wave in clinical scenarios like hypothermia. Right, in clinical scenarios like hypothermia. So in patients with hypothermia also there will be a long QT interval. So if you take the QT interval in these individuals, it is definitely prolonged. It is more than 440 milliseconds. But along with the prolonged QT interval in patients with hypothermia, there is an additional wave that is called as the Osborn wave. And in hypothermia, what are the other changes? The other changes what you will have is the bradyarrhythmias, Osborn wave or the J wave, and almost all the intervals are prolonged. The PR interval, the QRS complex and as well as the QT intervals will be prolonged. And there will be also presence of the shivering artifact. I'll just show you that particular ECG with shivering artifact. There can be ventricular ectopics and finally there can be cardiac arrest. That is what is the ECG changes like what you will have in patients with the hypothermia. Now let me just show you the ECG with the shivering artifacts. That includes, so this is the ECG with shivering artifact. So shivering artifact in a patient with hypothermia, right? So this is the, so you can make out here, right? So the isoelectric baseline, it is not straight. So you have abnormal isoelectric baseline which is secondary to this particular shivering effect. So shivering artifact in a patient with hypothermia, that is what you see in case of, that is what you will see in patients with the hypothermia. Now remember, in hypothermia you will have the prolonged QT interval and as well as the Osborn wave. And what are the other clinical scenarios where you can have the prolonged QT interval? And the other causes of prolonged QT interval, it includes the myocardial ischemia and as well as the post-cardiac arrest, apart from the clinical conditions which we have discussed. So, you see the question here. QT interval is shortened in hypocalcemia, hypokalemia, hypercalcemia, hyperkalemia. So, I have said you, related to calcium disorders, hypocalcemia, the QT interval will be prolonged. Hypercalcemia, the QT interval will be shortened. Right? Now, this particular hypercalcemia, when do we call? Normal calcium levels are 9 to 11 milligrams per deciliter or milligrams percentage. When the calcium levels are more than 11, then we use the word this hypercalcemia. So you have a condition called the hypercalcemic crisis. So this particular hypercalcemic crisis you will see in case of the malignancy. Now, in which particular malignancies you will have this hypercalcemic crisis? You will have this in case of the carcinoma of the breast, and you will have this in case of squamous cell carcinoma of lung. Right, squamous cell. So these are the conditions where you will have this hypercalcemic crisis. Now, whenever there is hypercalcemia, the individual can have the cardiac arrest, and the cause of death in case of hypercalcemia, that is the systolic arrest. Right, the cause of death in patients with hypercalcemia is the systolic arrest. Now, how do you treat these particular patients with the hypercalcemia? In patients with hypercalcemia, the first line treatment is the normal saline. So what this normal saline will do? The normal saline will cause the dilution effect. So it will cause the hydration. So hydration will decrease the calcium. And apart from the normal saline, the diuretic. And that particular diuretic is your furosemide. Right? And this furosemide, it will cause the calcium loss within the urine. It will cause calciuresis. And one of the cause for hypercalcemia is hyperparathyroidism. And what this hyperparathyroidism will do? It will cause the bone resorption. So, we have certain group of drugs which will reduce the bone resorption, and that is nothing but your bisphosphonates. And within the bisphosphonates, that is ibandronate is the drug of choice. And the next important drug is the calcitonin nasal spray. This calcitonin nasal spray, it will send the calcium into the bone from the plasma. That is what the calcitonin nasal spray does. So these are all the causes for, these are all the treatment options for the hypercalcemia. And hypercalcemia will cause the short QT interval. See, until now, like what we have discussed was the conditions which was causing the long QT interval. Now, let me discuss the conditions which will cause the short QT interval, and one among that is your hypercalcemia. Now, followed by that, we have many electrolyte abnormalities, right? So, hypocalcemia is there, and as well as the hypercalcemia. Regarding hypocalcemia, let me tell you one important point, that is what is the cause of death. In hypercalcemia, the cause of death is the systolic arrest, whereas in hypocalcemia, the cause of death is the laryngospasm. So, in hypocalcemia, what the individual will land up in? The individual will land up in what is called tetany. Right? The individual will land up in what is called tetany. So, tetany is mainly because of decrease in serum calcium seen in thyroid surgery. And what will be the features of the hypocalcemia? That will be in the form of perioral and as well as periungual paresthesias. Right? So there will be perioral and as well as the periungual paresthesias. And in these patients with hypocalcemia, you have the two important signs, that is the Troche's sign and as well as the Chostek's sign. So these are the two important signs in patients with the hypocalcemia. Now, Apart from that, in case of hypocalcemia, the cause of death is laryngospasm. Laryngospasm, the individual will have the stridor, and this will make the individual to land up in death. So this is about the hypocalcemia clinical manifestations and what is the cause of death. And how do you treat this particular hypocalcemia? Number one, if you take the ECG, there will be prolonged QT interval in hypocalcemia, and the drug of choice in hypocalcemia is the intravenous calcium gluconate has to be given. And the other important cause for hypocalcemia is surgically induced hypoparathyroidism. So in surgically induced hypoparathyroidism, drug of choice is injection teriparatide. So injection teriparatide is given for surgically induced hypoparathyroidism. Okay. Now, after having discussed about the cause of death in patients with hypocalcemia, which is nothing but laryngospasm, let me tell you what are all the various causes of death in other electrolyte abnormalities. Like for example, you take in hyperkalemia, the cause of death is diastolic arrest. Hypokalemia, the cause of death is the respiratory paralysis, right, where the individual will have the diaphragmatic palsy, secondary to hypokalemia. And you take hypercalcemia, the cause of death is the systolic arrest. And hypocalcemia, the cause of death is laryngospasm. So in hyperkalemia, the treatment is, the drug of choice is the calcium gluconate. And in hypokalemia, the drug of choice is the potassium chloride supplementation. And in hypercalcemia, the drug of choice is the ibandronate, if it is secondary to hyperparathyroidism. Whereas the first line drug in hypercalcemia, it is your intravenous normal saline. And for hypocalcemia, the drug of choice is calcium gluconate. So these are all the various causes of death in various electrolyte abnormalities. So one of the cause for short QT interval was hypercalcemia, which I have discussed now. Now what are the other causes for short QT interval? That includes congenital short QT interval and as well as the digoxin effect. So these are the two other conditions where you can have the short QT interval. And let me tell you what are the ECG features of the digoxin effect. So in digoxin effect, the ECG features include the PR interval prolongation, ST segment depression, and the QT interval being shortened. And even if you take the ECG of these individuals, that ST segment whichever is being depressed, right, the ST segment whichever is being depressed, that will give you a classical, the hockey stick sign on ECG, and that is what is suggestive of the digoxin effect, right? And let me show you that particular ECG changes. So this is your classical ST segment depression. So this is nothing but your inverted mustache sign, or we call it as the hockey stick sign within the ECG. And this particular ST segment, it is being described as the reverse tick sign, or the hockey stick sign, or Salvador Dali's mustache sign, right? Salvador Dali's mustache sign. These are all the various names that is being given for the ST segment which is being depressed in case of the digoxin effect. So you see one entire ECG complex or the ECG of the digoxin effect. So you can observe here that the ST segment is depressed, and that is being depressed in the form of an inverted tick sign. And apart from that, if you measure the QT interval in these individuals, QT interval is also being prolonged, right? The QT interval is also being prolonged. So along with the ST segment being depressed, the QT interval will be shortened in these individuals with the digoxin effect. Now, apart from digoxin effect, we have what is called digoxin toxicity. In case of digoxin toxicity, arrhythmias are more common. And in case of digoxin toxicity, you will have all the types of arrhythmias except atrial fibrillation. Now, what is the most common arrhythmia you will come across in patients with the digoxin toxicity? The most common arrhythmia you will come across is ventricular bigeminy. Right? Ventricular bigeminy. That is the most common arrhythmia, like what you will come across in patients with the digoxin toxicity. So, if you take this bigeminy, it is a sinus rhythm with frequent premature ventricular contractures in a pattern of the ventricular bigeminy. So, you see that particular ECG strip. So, this is a normal complex and this is your premature ventricular contractures. And if you take this premature ventricular contractures, you are seeing them every alternative complex. See, this is a normal complex and this is a premature ventricular contracture. This is a normal complex, this is a premature ventricular contracture. This is a normal complex and this is your premature ventricular contracture. Okay, so which is nothing but your ventricular bigeminy. That means every alternate beat is an abnormal beat. So that is why it is called bigeminy. Next, followed by that, you see another example of the digoxin toxicity. Right, so this is another example of the digoxin toxicity where you are observing, right, if you can make out here, this is the normal complex and this is your ventricular premature contracture. And that ventricular premature contractures, if you observe here, you are making out this particular ventricular premature contractures every alternate beat. So this is also ECG of digoxin toxicity with ventricular bigeminy. Now, if you take the other important clinical condition where you have the QT interval being shortened, you see a question. The QT interval is being shortened in hypocalcemia, hypokalemia, hypercalcemia, hyperkalemia. So this already we have discussed, that is in case of the hypercalcemia where the QT interval will be shortened. So this is about the clinical conditions where the QT interval is being shortened. So I have explained you the QT interval where it is being prolonged and then I have explained you the QT interval where it is being shortened. And in the next session of mine, I will discuss the Torsades de Pointes. So I said you this Torsades de Pointes, it is the precipitation of the prolonged QT interval. So in the next session, we will discuss in detail about the Torsades de Pointes. Thank you very much.